Is this good? Good, thank you. Tune it up. There we go. So I want to draw your attention while you're listening to one, just our two. So there we go. There are a couple of PDFs that are graphics of what I'm going to talk about, and then there's a JAMA Psychiatry Viewpoint, which talks about the project that we did here, OMH did in partnership with the health department, and that we're very proud of, and I'll say a word about, and then what comes after that. But many of you are accustomed to dinner and a movie. So this is lunch and some videos. So you had your lunch, and I'm going to show you over the course of my 20 or 30 minutes, I'm going to show you 3 5-minute videos. The first one is borrowed from the University of Washington and its Technical Assistance Center called the AIMS Center, and it is a collaborative care. It is what collaborative care is. And we're on a mission here to try to let you and everybody else know what collaborative care is, because it's really important to do collaborative care, as people know, with a capital C, not just collaborative care. You know, waving to a social worker across the street is not collaborative care. Collaborative care is a very prescriptive set of methods that are embedded into the daily practices of primary care, and there have been 80 replication studies of this, and when you do it, it works. And if you don't do it, you'll discover it doesn't work. So first, here is a video, the first of your 3 videos on collaborative care from the AIMS Center.
He was so outgoing, and everyone liked him, and he did really well in school, and the teachers always loved him.
We moved to Washington from Oregon when I was 11. And then from there, it just seemed really lonely. It was hard to make friends, and just seemed to kind of go down from there.
I kind of noticed things happening around when he was 16. He would get really defiant when we were asking questions, and wouldn't really give us direct answers, and wouldn't tell us where he was.
I was very guarded, and it seemed that more and more of the anxiety was coming out. I just felt kind of lost, like not really knowing what the problem was, so I didn't really know how to address it. And the worse that got, the more I was self-medicating. Every once in a while it became like every day, and every day became like all day, and then it just became harder and harder to manage, and it just seemed to snowball. And it just got darker and darker, and it was just, it didn't really seem like there was any way out. I just felt completely buried by it. And then it finally caught up with me.
One Saturday, I was in Portland with a girlfriend buying some school supplies, and I got a phone call from my husband, and he said that Danny hurt himself.
I felt that at one point, if I could push enough people away, that I wouldn't have to worry about it, that no one would miss me when I was gone.
So finally, I got it out of him that Danny had slit his wrist.
Daniel was referred to Country Doctor, a community health clinic that practices collaborative care. Collaborative care provides mental health care in primary care and other familiar settings where most people already receive their medical care. It's a patient-centered approach that builds on the existing relationship between the patient and primary care provider. Unlike usual care, collaborative care gives mental health care support to primary care providers by adding new members to the care team.
When I see a person in primary care, I have 15 minutes with them. And it's very difficult to make a mental health diagnosis in 15 minutes. It helps to have somebody who has time to really fully assess a person's symptoms and get the correct diagnosis, and then work with a psychiatrist to get the best treatment plan.
That person is the care manager, the third member of the collaborative care team. The care manager manages the overall treatment plan, provides brief psychotherapy proven to work in primary care, supports medication management, and facilitates communication with all members of the team, especially the patient.
Daniel was referred to me through his primary care provider, Angel, and he was having a lot of health concerns, but also experiencing pretty significant anxiety symptoms and ADHD symptoms.
The fourth member of the team, the psychiatric consultant, works closely with the care manager to provide a mental health diagnosis and speaks with a primary care provider or patient as needed. The psychiatric consultant and care manager work together to develop treatment plans, usually over the phone, using a caseload approach.
My role is to be able to know what are the evidence-based treatments that we can use to help patients with depression. So one of the things I can do is have a variety of options for the primary care provider to try when patients don't respond to first-line treatment.
So she would make recommendations, and then my role would be to make sure that those recommendations were relayed to Daniel's primary care provider.
The fact that I could go to a checkup visit to see Angel and have her already know what Annie and I discussed was so much easier than me trying to remember with everything else going on, like, oh yeah, what did we talk about last week?
It helps me feel really confident in the diagnosis that is eventually given.
Collaborative care takes a population-based approach to mental health and uses a registry to track clinical outcomes over time of every patient being seen. This shapes the treatment plan and focuses attention on those patients who need the most help.
One of the things that's really unique about collaborative care is because we do that tracking over time, we can actually kind of hold the memory a bit for patients sometimes and help them actually see their progress when they don't see it. So sometimes patients get stuck and they can feel like nothing's getting better because the work of changing is so hard. People can kind of want to give up.
So this video you can get from the AIMS Center. It's much longer than this, but I think I hope it gives you a sense that this is a highly structured, prescriptive set of activities, which means it's really hard to do. However, in the Hospital Medical Home Demonstration Project, 19 academic medical centers, 32 clinics did this for 2.5 years, ending this December 2014. And we, OMH, did the technical assistance. The funding for these, paying a lot for its indirect costs, came through the federal dollars, the grants, and we have demonstrated actually that it works. And we also found out that it doesn't work right away, that a lot of the clinics that actually got to the performance measures that we established got there in the last 6 months of the grant. And in part, they did that over time, getting to learn to do it better, but in part because we threatened them to cut off their money. And we also told them that unless they did it right, they weren't going to get a shot at the continued funding that was going to be installed in the budget, in the Medicaid budget, which is where I'll finish up today, because we did manage to convince Medicaid and the state that this is an intervention, a necessary part of primary care that needs to be paid for. And when a grant expires, that service typically ends. And now we've built this in. We have limited resources, so we've rationed it, but we have 3 cohorts continuing. The academic medical centers, we're adding some FQHCs, and we're going to add some IPAs. And I'll come back and finish with that. So this can be done, but what I don't know how to do is to get to the next. Here it is, okay. Okay, so the next video, I have to warn you, is going to be painful. Well, but then it's going to be, your pain is going to be relieved by the subsequent video. So, how many of you know what motivational interviewing is? Okay, so this video, first video, is an encounter between a pediatrician and a mom, in which the pediatrician is trying to counsel her about smoking cessation. And it's really uncomfortable, what she does, and really uncomfortable for the patient, as you will witness. So this is how not to do motivational interviewing, how not to be with your patients, and then we'll take a look at how actually to do it.